Thank you so much, Dr. Vikram Patel, for joining us. Welcome everyone to an interesting and probably a most important conversation that we need to have. We probably had a fair bit of these interactive sessions, and every time we go back talking to either the student community or the academic community, we keep hearing that there's always fresh questions, there's new perspectives, and hence we continue with finding some answers and some perspectives to the many questions we have about mental health. Welcome everyone to Reimagining Mental Health for All, hosted by Krea University. And we have today with us Dr. Vikram Patel. Quick couple of words. Dr. Vikram Patel is one of the world's leading researchers and practitioners in the field of mental health, and he's pioneered effective treatments of mental health issues in regions with sparse health resources. Dr. Patel is the Pershing Square Professor of Global Health and Wellcome Trust Principal Research Fellow at the Harvard Medical School. He co-leads Global Mental Health at Harvard Initiative. His work has focused on the burden of mental disorders, their association with social disadvantage, and the use of community resources for their prevention and treatment. He's a co-founder of the Movement for Global Mental Health, the Center for Global Mental Health, the Mental Health Innovations Network, and Sangat, an Indian NGO which won the WHO Public Health Champion of India Prize. He's also a fellow of the UK's Academy of Medical Sciences and served on the committee which drafted India's first national mental health policy and the WHO High-Level Independent Commission for NCDs. He has been awarded the Chalmers Medal, the Sarnath Prize, the Pardes Humanitarian Prize, an honorary OBE, and the John Dirk Canada Gairdner Award in Global Health. He was listed in Time Magazine's 100 Most Influential Persons of the Year in 2015. We're absolutely delighted, honored, privileged to have you amongst us and to just be in your company. Thank you so much. And as for the format today, we will open the floor to you to talk to us and give a brief address on the topic, which will be followed by some moderated question and answers. With that, welcome everyone once again. And thank you, Dr. Patel.
Thank you very much, Kala. Just to confirm, you can hear me? Okay, great. So thank you so much. It's a real pleasure always to speak to a student community. And this is my first time of speaking to the students of Krea University, which I've heard so much about. And so it's a real delight for me to be speaking to you today. I think it's a particularly important subject for students, not least because as young people, you embrace the future, but equally you are most disturbed by some of the events that have been happening in our country in the last few months, indeed, perhaps a year even. Of course, the subject of mental health almost always crops up when we consider some of these disturbing events. The suicide more recently of the celebrated actor Sushant Singh Rajput once again brought the subject of mental health right onto the front pages of our newspapers. And of course, this suicide occurred just days after that of his manager. And it was very interesting for me to observe how the media, as well as many other individuals in the country reacted to this, which I thought was, to a large extent, actually quite thoughtful. I know there have been some instances of insensitive remarks and reporting, but by and large, I am contrasting the reporting and the reaction with memories of similar events happening, say, 25 years ago when I first started working on this subject in India, when actually the newspapers were gory, they were gruesome, they really painted the person who had ended his or her life as someone who was a weak person, was a person who didn't work hard enough to try and make a better life for himself or herself, etc. These are all the kinds of very negative images. And of course, there was a more broad negative image about mental illness more generally. But on the other hand, this time around, even someone like Milind Deora, who's a very prominent politician, politicians are often the people who are the last to admit to mental health problems because they fear that the shame and stigma attached to mental illness may damage their political careers. But on the other hand, we had this politician speaking very openly about his own tryst with depression. And it strikes me, therefore, that India as a country has made enormous strides in the last 2.5 decades in terms of recognizing openly the importance of mental health. And I believe this has been a long time coming because, as I would argue, mental health is not about mental illness. We need to not conflate these two ideas. Mental health is something that is integral to each and every one of us. And indeed, if one had to strip away our physical self, I often say, if you had to remove that part of myself that you can see and touch, what is left of me is my mental health. And in fact, in that sense, it is at the heart of who we are as human beings. It's at the core of our personhood. And I am so glad that people are talking about mental health beyond mental illness. Now, obviously, what often brings conversations of mental health out into the fore is when mental health has been impaired or has been damaged in one way or another. And right now, we are going through one of the most extraordinary events of modern times. Certainly, it's the most extraordinary event of my life, and I'm sure it would be the most extraordinary event of every single person on this webinar. And of course, this is the pandemic that has swept our country and indeed the whole world. And there's been a lot of conversation about the impact of this pandemic on the mental health of the population. And I have been thinking a lot about this. Is this a single narrative, or are there multiple narratives that one can examine the mental health consequences of the pandemic? And it seems to me that in a very crude way, I see this really as having two overlapping acts, if one can imagine what is happening to us almost as a surreal play. There are really two overlapping acts that are quite relevant for our conversations today. The first act really began, I'd say, around March this year. And in my mind, the mental health consequences of the pandemic in the last 3 or 4 months in that first act are characterized by a pandemic of fear. And this fear, in my mind, is largely the consequence of the profound uncertainties which have overwhelmed all our lives. We now know very clearly that one of the most stressful aspects of life is the uncertainty that certain aspects of our life bring to us. For example, the uncertainty that comes with poverty, the uncertainty whether, for example, I will have a meal tomorrow, or whether I'll be able to secure a meal for my family. The uncertainty that comes in certain conflict-affected zones, for example, the uncertainty of my own physical well-being. Will I be a victim of some attack in the days ahead? These sorts of uncertainties are profoundly toxic to our mental health. Well, in the last few months, we have faced uncertainties in virtually every single aspect of our well-being. From the very physical nature of the infection, will I be infected? What will it do to my physical health? What will it do to the people around me, particularly our elderly relatives who we are particularly concerned about? To the uncertainty about the future. For example, will my job prospects be affected? And if I'm already in employment, will I even have a job at the end of this pandemic? To the uncertainty about the governance of our country. Why, for example, is the country facing a surging epidemic, even though we had the most stringent lockdown in the world? And indeed, I remember very clearly when the lockdown was announced in the last week of March, we were told that by May the 16th, we would have 0 cases. Why is it that in spite of all those promises by some of the leading scientists and political leaders in our country, are we facing what we are seeing right now? Is that, leave aside no cases on May the 16th, we are seeing an epidemic unfolding in astronomical proportions around the country right now. How is that happening? The uncertainty about whether or not the country is actually being managed in a way that can at least see the end of the epidemic in the very near future. And ultimately, of course, that's linked to the uncertainty about when life, if at all, will ever return to normal. And if you think of all these uncertainties, and uncertainty being such an important aspect of our mental health being affected adversely, it is not at all surprising to me that there are waves of anxiety, fearfulness, sleep problems, irritability, and hopelessness sweeping across the land. Now, the important point I want to make is this. These are rational responses. These are completely normative responses, because responding with anxiety and fear is the natural human evolutionary response to uncertainty. And so it's extremely important that we do not medicalize these responses, but instead try and understand and then address the uncertainties that are producing them. Of course, some of these uncertainties lie beyond our control, but we can still do a lot to manage them. And certainly in the question and answers, we can certainly talk about those a little bit more. That said, it's also important for me to acknowledge that many in our community were already suffering from mental health difficulties before the pandemic, and it is completely possible that these uncertainties are all that was needed to, as it were, precipitate a full-blown relapse of a mental health problem in those individuals. Now, I mentioned that there are really two acts in the way I see it, in a very simplistic way, two acts through which the narratives of impaired mental health might be understood in the context of the pandemic. And it's the second act, which I believe is far more sinister. This act really is about the emergence of another pandemic. And this is not the pandemic of the virus or the pandemic of fear, but the pandemic of mental illness. I'm reminded by of the words coined by the Nobel Prize-winning economist Angus Deaton, the deaths of despair. In fact, these are words that he coined, and along with his colleague Ann Case from Princeton University, published a book in April this year. And this particular book and this metaphor is used to describe the reasons for the reduction in life expectancy of working-age Americans following the economic recession of 2008. Now, it's interesting, the choice of words. This is not deaths of hunger. This is deaths of despair. And I think in that word despair, Angus Deaton and Ann Case really point to the fact that the loss of hope, the loss of purpose, the loss of meaning in one's life, very abstract ideas, but very central to mental health, are actually directly toxic to our physical well-being. Indeed, suicide and substance use related mortality accounts for most of these deaths. It's quite fascinating when you think about the fact that the US is the only developed country which has actually seen a fall in its life expectancy in the last decade, and almost all of that has been driven by the deaths of despair in working class Americans. And much of the particular problems of US society that Deaton and Case speak to are very relevant to India as well. These are growing inequality. You may already know this, that it is an incredibly disturbing fact that India is today one of the most unequal countries in the world, and it wasn't that way 40 years ago. The weakening position of labor, the deep polarization of our society in a variety of different social strata, and of course, tied to that, the complete lack of prospects of the future due to the economic recession. This economic recession facing India will be far worse than what's facing the Western world, because our economy was already very weak as we entered into the pandemic. Not only do we share many of the ills of American society, but we also have to deal with the colossal numbers of people who are absolutely impoverished. This is something America does not have to deal with. And on top of that, we have to deal with the fragmented mental health care system, which even before the pandemic failed to reach more than 5% of our population. This makes for a perfect storm, as I wrote in a recent piece in the Indian Express, of a pandemic of mental illness sweeping our country. Just to tell you what the situation was before the pandemic, mental health problems already affected about 10 to 15% of our population, and this is by the government's own data through the National Mental Health Survey, and that a third of all female and a quarter of all male suicide deaths in the world were occurring in Indians. Now, Indians only account for 10% of the world's population. So you can begin to see the disproportionate impact of inequality, poverty, and a variety of other social ills on the mental health of Indians even before the pandemic. Now, it's true that a lot of our current attention on mental health is coming due to celebrities. And I think this is an important recognition. It's really good to see celebrities talk about their mental health problems. Tragically, when celebrity suicides occur, this, of course, brings mental health onto our front pages again. But it's interesting, we only think of mental health in that context because we struggle to imagine why would someone who has such a celebrated life have such emotional suffering. And so the only explanation we can invoke in those situations is mental illness. But the truth is that it is the poor, the dispossessed, the marginalized who bear the greatest burden of mental health problems. And this is, of course, evidence that comes from a large body of work, including my own, that has, at a population level, tried to understand the risk factors for mental illness. For example, gender-based violence. This is a very, very major risk factor for depression and suicide in women. But we've historically dismissed the suffering of those who are already suffering because of their social condition as a natural extension of their social and economic conditions. And it is this vast section of the population which will be disproportionately affected by the economic recession. So I want to turn to something positive to close off my remarks. There are solutions. Of course, you know, in the light of the pandemic, we can already see some really innovative stuff going on. For example, the use of telemedicine platforms that allow us to reach the unreached by using digital platforms. You know, the old-fashioned ways of having someone come and see a doctor or a psychologist no longer needs to be the only way to deliver mental health care. We also see a huge growing importance on psychological treatments, and that's wonderful because for far too long, mental health care has really equated the prescription. And we know that that is a very narrow view of what mental health care should look like. It's because doctors and drug companies have no interest in psychological therapies. And therefore, by actually seeing telemedicine come to the fore, automatically psychological treatments have also been carried into the forefront. But there are two big problems with this whole approach of telemedicine. The first is, of course, that all the providers still remain mental health professionals who we know from the very beginning. We only have 5,000 in the country. Can you imagine? 5,000 for 1.3 billion people. They're very scarce in number. And of course, you know, most of them are in the private sector and are unaffordable to the vast majority of our people. And the second challenge, of course, is the digital divide. You know, digital literacy, as well as adequate connectivity, still remains a very problematic goal for large groups in our population. And of course, therefore, the reliance only on digital tools for delivery of care will sometimes only further increase the inequalities in access to mental health care. So what's the really exciting innovation? And this is, of course, an innovation that goes back to what I think is probably India's greatest contribution to global health. This is an innovation that predates mental health. It's an innovation that I believe has transformed healthcare in India. And no, it's not tertiary hospitals. It's not the celebrity doctors. It isn't all the technology that you read about. It's the humble community health worker. It's the humble, ordinary person who has a calling to care for others. 50 years ago, this dramatic innovation took seed in our country in the Mitanin movement in Jharkhand. Since then, it has morphed into the ASHA worker and a range of other community health workers who have transformed maternal and infant health in India today. Today, we were reading about the dramatic reductions in infant mortality in India in the last few years. This is to be celebrated, but let me be honest, this is not because of tertiary hospitals. It has actually entirely been driven by the improvement in the social conditions of women's lives, for example, women's literacy, but also the ASHA worker key goal of mobilizing women to have better antenatal care and to have institutional deliveries. Many years ago, about 15 years ago, I actually started asking myself the question that if we could deploy ordinary people in India's rural and urban communities to be trained to provide such life-saving interventions that were transforming our health indicators, well, why not think about mental health care as being one of the areas of work that they could be engaged in? And thus began a journey with the organization Sangat. And over the last 15 years, we have been experimenting with a variety of different interventions for mental health problems, both in the prevention space, for example, promoting young people's mental health by altering the social environment of their educational institutions, all the way to treatment and recovery. And even in that area, a huge diversity of target groups, from autism in children to depression and drinking problems in adults to supporting families of older people affected by dementia. And all of these different innovations have been really grounded in the same set of values, that with appropriately designed interventions that have been simplified without losing their effectiveness, to remove all the unnecessary jargon, appropriately simplified interventions, appropriately developed training programs, and supervision for quality assurance, we can actually deliver mental health care in any context in the country. Of course, Sangat is a science organization, and a huge amount of our work has been not only in designing such interventions, but then running randomized controlled trials, which many of you will recognize is the highest kind of scientific experiment in medicine and public health. We've run the largest randomized controlled trials in India for everything, as I said, from school mental health promotion all the way through to treatment for mental health conditions, and demonstrated the incredible effectiveness of these interventions. Today, friends, our work has gone viral, not just in India, but overseas. A brief psychological treatment for depression comprising 6 to 8 sessions delivered by a lay health worker now has the unique distinction of being the only mental health intervention designed in India which is being implemented in wealthy nations like the US and Canada. Sangath is now forging partnerships not just with international universities like Harvard Medical School, but with several state governments in India to scale up these interventions so that we can actually reimagine how mental health care can be delivered in every corner of our country. So I have a lot of things I could say to each of you about how this is done, what you can do to participate in this, but I really want to leave that for the Q&A, and I want to really close by making a plea for all of you who think about mental health care, but also a plea for those who finance and provide mental health care. This is truly an epochal, historic opportunity to invest in and transform India's healthcare system, particularly its mental health care system. We not only were deeply underperforming before COVID-19 hit us, but the scale of need is going to grow astronomically in the months and years ahead. Simply putting more money, and of course we do need more money, into an already dysfunctional system will not fix this problem. Yes, we need more money, but we also need to be guided by the best science on how we can reach the large sections of our population who are currently unreached. And to do that, mental health care must embrace the diversity of experiences and strategies at work. We must move well beyond the narrow confines of traditional medical approaches to mental health with its emphasis on doctors, diagnoses, and drugs. In my mind, we know how to go, we know where to go, we know what we need to do, and I cannot imagine a more valuable investment in response to the most serious health crisis facing our country since our independence. So I'll stop there, Kala, and hand back to you.
Thank you. Thank you so much. I'm going to take a couple of extensions from what you said before we actually frame questions in that. I was very intrigued with this, the task shifting concept that you actually spoke about in something like that, in this bit about social interventions. So can you just walk through an example on how this concept of task shifting makes interventions and care more involves everybody and makes it for everyone?
Yeah, I'll give you a very practical example of that. And also I'll tell you a little bit about what we're doing with that idea. So first of all, to say it's task sharing, I prefer that word because task shifting assumes that somebody else was doing the task, which of course in India is a false assumption. Nobody was doing the task. So it's actually sharing mental health care tasks. And actually, I think at the heart of this idea is that mental health is too important to be left to one professional group alone. It actually means that everyone must be involved. Each of us needs to be involved in caring for ourselves, but also that a variety of different kind of providers can be involved in catering to different kinds of needs that people have when their mental health is affected adversely. So let me give an example of what we did with depression. We start off with the best science of the world. Most of that comes from the North. It comes from a deep-rooted history, 100-year-old history of psychological science, really, about what leads to depression and how it is maintained or sustained. And therefore, that understanding of the mechanisms of depression then leads to psychological techniques that are used to teach people who are depressed skills in order to recover. Now, there are very complex treatment packages that have been designed by psychological science. Cognitive behavior therapy is probably one of the best examples of that. So what we do is we examine what is the key ingredient of CBT that actually produces most of the improvement in depression outcomes. At the same time, we also do very deep-rooted work in our own communities about what people do when they're depressed. Remember, depression is as old as humankind. It's actually an evolutionary a response to stress. And so obviously people have, from an evolutionary perspective, already developed techniques to help themselves when they're depressed. So we then marry these two kinds of evidence the evidence that comes from our grounding in our local communities, really using social science methods, as well as really highly sophisticated psychological science, and we design a simple intervention that keeps the essence of what psychological science tells us, but also marries it to the context in which we're going to deliver it. The next step is we develop a blueprint. The blueprint is really a learning curriculum like you would design for any subject that you would be doing for your students. What are the key learning competencies that you need in order to be able to understand this treatment and how it's delivered? We then design a training program that is competency focused. And what's really exciting now is we're doing the whole thing digital. The idea really here is you don't have to come into a classroom, which is impossible to do when you want to train 1 million health workers. But instead, we design a very systematic process of going from a treatment manual, like you can think of that as a textbook, through a blueprinting process to a digital curriculum. The digital curriculum is then fully digitized using largely video-based learning, so that people with low literacy can actually still learn the treatment because there's almost no text. And then we design competency assessments that are designed to distinguish those who have completed the training from those who have not. After someone is trained, and it's important to remember, you never became a good driver simply by doing a classroom course. You become a good driver by first knowing how to drive, the rules of driving, and then you practice driving, with someone holding, not literally, but hand holding you through the process of driving. And so here we have the second phase of learning, which is case-based learning. So the person is actually going to start delivering their knowledge, but in a mentored form. And we're designing a digital platform for that as well. So that Empower, which is the program that I'm so excited about, it's really to take this innovation to scale rapidly, is building the digital tools for learning, as well as the digital tools for supervision and case-based learning, so that by the end of this year or early next year, we will have all of this in place and we can scale up the depression treatment for task sharing to community health workers pretty much anywhere in the country, but focusing initially on the Hindi-speaking states, because the content obviously needs to be linguistically accessible to the frontline workers, and the language we're working in right now is Hindi.
Fabulous. And I'm sure, we can't, of course, get many of our students to get working with Sangat and Krea more formally with Sangat. So looking forward to learning more on that. Just connecting to that bit around the education institution angle, which is what I want to touch on, that one of the major problems, especially with developmental disorders, is that the majority of them remain dependent on poor quality education or inaccess to work and other support. So what would be your thoughts or perspectives on how we can probably educate employers or even institutions like us in creating inclusive environments for neurodiverse individuals out there?
Yeah, so I think this is a really important question you raised, and Sangha does a lot of work with people affected by autism. Now, it's important, I think the word you use, neurodiversity, is so important, and I think this is a fairly new idea, to be honest, and not accepted by everyone either. Like many new ideas, it's a contentious idea. Is, for example, autism or intellectual disability, is it actually a part of the variation of, or the word diversity captures it, the diversity of humankind, in the same kind of way that some people are shorter, some people are taller? Do you also have similar spectra or diversity for emotional functions, for cognitive functions, and so on? And is the disability actually a product of the intolerance and lack of inclusion of society? That is to say, if society was fully inclusive in the way that we would aspire to it, then there would be no disability. And you can see this actually very interestingly played out in the case of people who are visually impaired. The disability of visual impairment is produced when society does not accommodate people who are visually impaired, for example, through having easy to navigate directions. And indeed, society has made a huge progress in that. And therefore, the disability associated with visual impairment has reduced dramatically. And so the point you're making is a really important one, is that when the impairment is in your cognitive functions, your communication functions, the sort of mental functions that we don't quite see visibly, is it the case that the social infrastructure of life needs to be modified to include people with those different needs. Absolutely. And I think one of the most important spaces where this needs to happen is in educational institutions, because exclusion begins there, particularly because these forms of impairments are present from very early childhood, and they come in the way of traditional orthodox methods of teaching and learning. By that I mean the teacher standing in the classroom with 50 kids in the class and basically using a blackboard. And the teacher, of course, is already doing a pretty tough job. And so I don't intend for a moment to blame the teacher for this, or put the responsibility rather on the teacher. It has to be a systemic change that recognizes that children with different needs require those needs to be met by alternative forms of teaching, alternative and oftentimes extra resources. Inevitably, that's what society has to invest in. And so if you're committed to inclusion, we should remember it doesn't come without a price tag attached to it. But that price is something we must agree as a society to pay, because we believe in inclusion, because we believe that every human life is worth the same. And if we do have that common set of values, then I think any amount of resources can be made available. Of course, what shape that takes, I don't want to spend too much time on that, but clearly within school is, I think, the key place to begin. Kala, in many ways, that is where you lay down the foundation for higher education, is actually in primary education and secondary education. Sangat has been working quite a lot. We have a program called Beyond Boundaries in Goa, which has been working with mainstream schools, and a huge amount of our emphasis is mainstreaming. So rather than the kids being removed to go to a special school, which creates a further, I think a further separation. It's in my mind not inclusion at all. It's actually exclusion. Admittedly, I think some children do have very special needs, but I think most needs should be met within mainstream schools. And so we have a program that is trying to create learning resources both within the school, but teaching materials and so on, that can enable children to learn effectively within schools, and particularly children with autism and intellectual learning difficulties.
Thank you. Yeah, just talking about the tools and the content that's created, right? So in societies like India, especially the non-Western communities, we have very limited research in this area and very limited content to work with. So in such a situation, how do you create what you call a culturally appropriate mental health care? You know what I mean? So it's just, how do you kind of sensitively go in some of these regions where literature, access to literatures may be difficult, but create this culturally appropriate mental care ecosystem?
So, culture is important in all places. We have, it's curious, and this is actually one of the ethnocentric natures of the field of anthropology. The idea that culture is only a variable in the exotic East. Somehow European society has no culture. And this is, of course, one of those, those false narratives that was exported with colonial rule. What affects Europeans is universal. What affects non-Europeans is culture. This is, of course, not true at all. Cultures exist everywhere. European societies are just as multicultural as ours is. And within European societies, you have subgroups in the population who have distinct cultural identities as well. So culture is universal and very diverse and constantly changing. It's also not written in stone. I find it hilarious sometimes when anthropologists used to talk in the 30s of African culture. It's almost like me saying white culture. It's racist and it's wrong. That said, the question you're asking, therefore, is how do we ensure that mental health care is culturally competent? And I think there are very many techniques and approaches very well defined by medical anthropology. I think that is the field which really sits at a wonderful interdisciplinary boundary between the humanities, having one strong foundation in the discipline of anthropology and in medicine. And the idea really behind medical anthropology is to acknowledge the centrality of culture in understanding how healthcare systems are organized, as well as at the individual level, how healthcare problems are experienced and acted upon. There's a huge amount of methodologies. Obviously, many of these are social science methodologies. In my own work, every single thing we do, every intervention we develop is developed in absolute participation with our so-called beneficiary groups. By beneficiary groups, I include three major stakeholders. The first is people with the target condition. So for example, if we're working with children with autism, there will be children with autism, but also very importantly their parents, because they're the ones we primarily work with. Second is the provider, who we believe is in the right place to deliver the intervention. And the third is the policymaker, the decision maker who has to finally finance. And so if the decision maker doesn't feel that this is the right kind of approach for them, you can do all the science you want, but it's going to remain only in the dry pages of a journal, which of course is no fun for those of us who are interested in seeing science being put to action. And so I consider each of these different cultures, because the culture of decision-making, the culture of healthcare systems, and the culture of ordinary communities are not all the same. There's some overlap, but they're also very distinct cultural spaces. And that is the way I, in a very simple way, participatory approaches is a central tool or principle, guiding principle for incorporating culture in everything we do in healthcare.
Thank you. Yeah, that was pretty interesting how you navigated that. That's I'm going to move to some of the questions that's come through both areas as well. So this comes from Sam. Sam is a part of our team that actually takes care of student life at Krea. And Sam's question is around the work you do in Sangat and checking on what kind of issues did you face in terms of execution? And this is particularly what's been the brush with the local law. Has that been supportive? Did you face any challenges while you were actually delivering what you were meant to deliver?
Yeah, great question. So, the first important challenge was credibility. I'm always reminded, one of my great, people I look up to as a source of inspiration are the Bangs, Abhay and Rani Bang, who began experimenting with community health workers to reduce newborn mortality in Gadchiroli in central Maharashtra. And I was very influenced by their work, but also the work of many other such pioneers of Indian medicine, the Aroles and so on. And there's a terrific book for those of you students who want to see this incredible laboratory of innovation that's happened in our country, called People's Health in People's Hands. And it was an edited volume by Dr. Antia himself, an iconic figure, a plastic surgeon who spent much of his career working with people with leprosy. You might imagine plastic surgery, global public health. Well, that's right. He was a plastic surgeon who wasn't beautifying already beautiful people, but was really helping using his tools to help reduce the deformities that often accompany the advanced forms of epilepsy. Leprosy. We don't see that much these days, but it was very common in the 70s. So, I learned from them, and essentially I learned that the single most important thing we need to do is not just be ideological. Ideology is very important. These are values, and I strongly believe in the values of equity, for example. But it's in science, you also have to prove. I think we need to be courageous. We need to invest the time and energy that we don't only stand on the soapbox and proclaim our ideology, but we also prove that actually what we're doing is in fact correct. And also be prepared with the possibility that you might land up being proven false. That's the scientific process, hypotheses, testing. And so I've done that. I've spent 10 or 15 years very patiently building a team of scientists in Sangat. This is no easy feat. Taking raw graduates from university and literally retraining them to do public health research. I spent years writing grant applications, competitively winning grants from some of the world's leading medical research agencies, making the case for why this is important. And I've been fortunate that they have overall always accepted my arguments. And then running very large studies, typically in partnership with state governments, which in turn requires a completely different level of engagement, working with health secretaries, ministers of health, et cetera, to convince them that this is a very important piece of work that they should be party to. This is a laborious, backbreaking piece of work. And it only ends when you complete the experiment, you write up the results. So credibility is the first thing. And I'll tell you what, without the science, we would not be where we are today. There's no way we would be where we are with the National Mental Health Policy, the National Mental Health Care Act, the World Health Organization guidelines, all incorporate Sangat's work as now, not just aspirations, but things that need to be done. The second is you have to disseminate the science. If as a dry scientist, many of us would just simply say, I published my paper in a great journal and now somebody can do what they want with it. So Sangat has always believed that we have to make sure that this science is heard and that it is acted upon. And to do that, we go to the next phase, which is that after we've completed these experiments, we've achieved the kind of credibility aspect. The next stage is to build the state systems to actually scale up. And so what I mentioned earlier, the Empower platform is exactly that. We're now at the sweet spot. We have the credibility, we have the science. We now need to build the capacity of the system to scale this up rapidly.
Thank you. This comes from a student, and this is touching back around, as you said, every time there's a celebrity incident, the topic of mental health comes to some surface at some point. So the question is, what can we do to diversify the dialogue around mental health and transform some of the misinformed notions that currently exist? So how do you bring about that actionable change as a student community? I would assume this question comes.
So, first of all, the person who asked that question, it is the student community that will embrace new ideas first. And it is a student community which will change the country, hopefully, in a direction that it needs to turn to. So first of all, I have huge faith and hope, actually, in the young people of our country. We're, a very wealthy country if we consider our wealth in terms of the youthfulness of our people. And I think for young people, one of the most important issues today is a society which is just, which is fair, where every individual is equal to the other. And these are all not just abstract political ideas, these are actually central to good mental health as well. Because one of the things we know is that a society which is socially coherent, in which there are strong social bonds between people, bonds of trust, bonds of identification, these are societies in which mental health as a whole is much better and suicide rates are much lower. And I think when people ask me, why are suicide rates so high in India? India has one of the highest suicide rates in the world. And it is because of all the toxic factors that I mentioned earlier, not least of which is inequality, which really I believe is one of the greatest sicknesses affecting our country. And of course, inequality is at an income level, but there is also another kind of inequality, which is to do with social stratification, which is historic in our country, particularly related to the caste system and more recently to do with religion. And I think these are things that every young person, if you really want to promote mental health of our country, every young person must be making it clear that a society that is built on equality and dignity is a society that we all embrace. The second thing, on a more immediate level, is to talk about mental health more openly. Be more comfortable, acknowledge your mental health in the same way that you acknowledge your physical health. And that is done in a very simple, unfussy way, by talking about the way you feel with your friends and family, by asking people, actually being sensitive to other people's mental health is just as important. It's like a mirror. If you can imagine other people around you like a mirror to yourself, you can be more aware of your own inner states, but you can also reach out to other people and say, hey, what's going on? You're not looking yourself today. Feel free to do it, because there is nothing wrong in doing that. And in the moment you do that, you will do two things. One is you will make the other person feel so much more comfortable to share what's going on in their minds. And secondly, you'll feel a lot better because you reached out to someone else. And one of the most important lessons from the rich history of what makes us healthy and live long lives is that reaching out to others, caring for others, not just individuals, but also groups in the community, is probably the best thing you can do for your well-being.
Thank you. So that question came from Viveka. I'm going to just quickly touch on this question from Ananya Raju, another student. And this, her question is more around the assumption that mental health, of course, not just exists in lower socioeconomic class. It's a taboo in major sections of the society, whether it's the rich or other classes. But there is a certain stigma that doesn't let them, come forward to seek help. And it is about how do we make this more simpler? How do we get people to come forward and ask for help? I'm guessing that to some extent you touched in terms of how do we provide, how do I support? But is there a way to break that stigma of mental health?
Sorry, Kala, you cut out a little bit there. Could you just repeat the middle part of the stigma with whom?
The stigma about seeking help.
Okay, yeah, okay.
Stigma around availing help.
So, people think that stigma is produced in, the general impression people have is stigma's got to do with superstition. The way to deal with stigma is to educate people. I don't think that's the only answer. I mean, actually, stigma is also related to the kind of care people receive. And I think it's important to recognize, who was the student who asked the question? What's the name?
Ananya.
Ananya. So Ananya, it's important to recognize that the history of psychiatric care, which has been synonymous with mental health because of my earlier remarks, that, we talk of mental health, but actually we're talking about mental illness. The history of mental health care in India has been completely and totally aligned with the idea of pagal. If you go to the average person in India and say, I work in mental health, let me be honest, even though we have a lot of conversations going on in our media and all, etc. But, the average Indian will say, oh, pagal ke saath kaam karte ho? It's the imagery is of the crazy guy. The guy who's talking irrationally, taking his clothes off, walking along the street, and you cross the road when you see the person, etc. That's the image. And then linked to that is the mental hospital. Now, here's a shocking statistic for you. Almost every mental hospital, barring one or two in the country, there's about 40 in India, were built by the British. And they still are 80% of all mental hospital beds in this, psychiatric beds in this country are in hospitals built by the British before 1947. These are places where we warehouse the sick, where people wander around naked, where there were grotesque violations of fundamental human rights, where the only treatment available was completely tranquilizing medication or ECT without any anesthesia. And people have seen this. This has become part of popular culture. It's part of our folklore. Look at Bollywood movies from the 60s, and you will see this kind of imagery. Now, ironically, of course, these asylums were shut down in Britain after 1947. They remain the central locations of mental health care in India. Now, I do think they play a role. They could play a very modern role, for example, for training and specialist care. But sadly, the imagery of the mental hospital remains. The National Human Rights Commission had an inquiry about 10 years ago, I think now, on the state of mental hospitals. It was appalling. They demanded a reform of these hospitals. Many of them have improved, but many of them remain a long way away from anything even remotely dignifying. So stigma is also produced by the provision of healthcare. And I think until we fix the way the mental health care system is organized, stigma will not disappear. Is there any stigma attached, for example, to HIV care? No, there isn't. Why? Because HIV care has been completely normalized. It's been mainstream. It's in every district hospital in the country. You don't have to go to some separate building with huge walls and locked gates anymore for HIV care. But HIV care was very stigmatized back in the 1990s because of the way HIV care was delivered as much as anything else. And so we need to reform both the public dialogue around mental health by having much more open conversations, but we also need to reform the mental health care system with its focus, as I said, on hospitals and diagnoses and drugs, and to create a much more diverse, community-facing mental health care system. Let me tell you, in my own work, I have never had a problem with demand. And that's because we approach mental health from a community perspective using metaphors and language that are non-stigmatizing. And most importantly, we use community-based workers delivering care in people's own home or in primary healthcare centers, not in hospitals.
Thank you. And I think that analogy that you used with HIV was just one of those light in the head moments. It said, yes, I mean, 10 years ago, if you actually even spoke about something like that, you get through a different reaction. And we hope we'll break that stigma. I know we've got only 5 minutes to go, and I want to let you go a little earlier than 5. There's one question that's come in the Q&A. I'm sorry, it hasn't identified themselves, but this is about, you spoke about how individuals who are suffering with mental illness are sometimes dismissed due to the underlying social tags attached to them. Could you please elaborate what that meant?
Yeah, when I started working in the, one of the major conditions I work on is depression. And depression often exists in people who have very difficult lives, often, not only. Okay, so this is not to say that, depression only occurs in poor people. No, not at all. It's just that the conditions of poverty increase the risk factors for depression. So depression is common in the poor, but it occurs in all strata of society. So I would be, told that why are you applying a biomedical framing to what is social suffering? If a woman lives with a violent partner and she is suicidal, can't sleep at night, cannot concentrate, sees no meaning in life, isn't this a normative reaction to living with a violent partner in a highly patriarchal society? What good is it to say that this woman also has depression? Well, I'll tell you, well, so that's the dismissal, that essentially, the experience of depression can only happen in rich people because they have no other reason to be depressed, as it were. But if you're a poor person or you have an awful personal life, well, then your depression is not depression in the sense it's not a health condition, it's just your misery of everyday life. Now, we know that that's not true for two reasons. Firstly, most poor people are in good mental health. Most women who live with violent partners are not depressed. That shows that these individuals this is not a natural consequence of disadvantage, that there is a particular combination of disadvantage with vulnerabilities that could be biological, that could be to do with life course stories, for example, early childhood experiences, that could be to do with other kinds of buffering factors that are present in the here and now, that actually mean that one individual who lives with a violent partner becomes depressed, but 5 others don't. And so therefore, it's clearly a medical condition. And secondly, we also know that when you actually provide the interventions that work to the person for depression, they actually get better. So they actually start sleeping better, they actually start being more hopeful. And when they do that, they can actually be in a much more capable position to deal with the stressors. So actually you're breaking the vicious cycle of disadvantage and poor mental health. Now, this evidence is fairly new. Nobody questions that now, to be quite honest. But all I'm saying is that, the media tends to focus on celebrity a lot more because, it's almost like, oh my God, this person had everything. Why did they end their life? Which is a very naive and stupid question, but that's oftentimes the way it is framed.
Thank you so much. We will keep this to 5 minutes before 5. So thank you so much. I'm sure there's lots of questions, and I'm supremely confident this is not the first time we're going to have you work with us, and we're going to continue this association. And can't wait to get, as I said, work with Sangat, and formally through Rakshi is of course on the webinar, but Rakshi leads the psychology practice at Krea, and through her we do look forward to some engaging time with Sangat and you as we go forward. Definitely the whole practice, the concept of it is very close to heart to many of the students at Krea. We have a very strong peer support program for mental health at the university. Currently, there is about what the student life is actually rolling out. So we'd love to share the architecture of how that's something we're conceiving, and we hope as an institution we'll pioneer some of these things and start to craft some of them for other young institutions, and also improve it as we go along. Thanks once again, Dr. Patel. That was fascinating. It was lively, and I just think it just gave us so many moments of, I didn't think about that. That's fantastic. So I think that's what we look forward to as we host many of these. Thank you once again for your absolutely precious time, and do look forward to continue working with you.
Thank you very much, Kala, and I certainly look forward to Sangat's collaboration with Krea University as well. Thank you so much for inviting me. Bye-bye now.